Scans, labs, and machines are powerful tools, but they don't tell us the whole truth. Your story does. Let me share a case that proves why the patient's story is often far more important than pictures. Michael was 55 when he developed searing pain down his right leg. His MRI looked clean. No disc bulge or herniation, no significant narrowing of the canal. Maybe he had a slight listhesis at the base of his spine, but it was reported as unremarkable. Michael continued to complain of the same searing, shooting pain, and the doctor was puzzled. Michael kept describing his pain: sharp, shooting, stabbing, tingling, electrical, intense, agonizing. The pain was worse when he was sitting, and it got better when he stood up and walked around. That detail didn't fit his normal MRI pictures. It suggested movement instability. As the pain continued, his doctor decided to use an old-fashioned technique and just get a simple x-ray. But not just a static x-ray, an x-ray that evaluated his spine when he bent forward and when he leaned back. And that's when the problem was discovered. That slight listhesis or slippage that was noted on MRI turned out to be a rather profound listhesis. There was a great deal of movement in the spine between bending forward and leaning back. This explained why sitting down hurt so much and standing up felt better. This also explained why the MRI didn't show a problem, because when the patient was standing up, his spine properly aligned. Just as when he was lying down in the MRI scanner, the spine was properly aligned. There was no obvious problem. But when he sat down or bent forward, you could easily see the movement of the spine, the listhesis. This listhesis was resulting in a pinched nerve at L4-5, causing the pain that shoots down his leg. The MRI had missed it. His story, combined with an old-school X-ray, finally identified the problem. This is one of the oldest lessons in medicine. Long before MRI scanners or CT scanners or even X-ray, doctors relied on history and physical examination to make a diagnosis. And usually they were right. Sometimes the patient's voice gives us the clearest answer. And here's why your story is the real key. Timing. Sudden versus gradual onset points to different problems. Quality. Burning, shooting, electrical, stabbing, numbness, tingling. They all point to different sources of pain. Location. Where do you feel the pain? In the back, in the buttocks, above the knee, below the knee, in the front or back of the leg. These all give us clues about where the pain may be coming from. What makes it worse? What makes it better? In Michael's case, standing up made it better. Sitting down made it worse. Examination findings. Is there weakness? Is there numbness? Is there loss of mobility or range of motion? All of these tell a tale. Images can support a story, but they rarely lead it. And the oldest tool, a conversation, combined with an X-ray, showed us everything. We got the X-ray because his story pointed us in that direction. Had we not listened to Michael, we probably never would have looked, because what can an X-ray show that an MRI can't, right? And here's the danger today. Everything is rushed. Doctors don't take the time to examine. They don't listen to the history. They hurry and get the MRI scan trying to get a diagnosis. But that's not how a diagnosis is made. Pictures don't tell the whole story. Your story isn't just the background, it's the foundation. That's why I built PainOptics, to put your story at the center, not at the margin.